Okay, so what do we want you to get out of this first panel? A lot of strategies. That's what we focused in on here, is we want you to strategize ways to develop strong community partnerships, to strategize how to assess needs and action plan priorities together with communities, to identify ways to make engagement more accessible, inclusive, and participatory, especially for diverse community members from minoritized communities, and to strategize how to keep that impact going long term, how to sustain those partnerships, get funding and resources there to sustain the programming that you develop together. So just to get us started, we just wanted to do a little bit more of an orientation to community-engaged research to build on what Susan started with this morning, just because it is the first panel. So what is community-engaged research? Here you're seeing some of the more formal definitions that are coming out from the Clinical Translational Science Network at NIH, as well as the CDC. And again, pointing to that this kind of research involves the community from conceptualization through data collection, through analysis, through dissemination, and through action. But in addition to these more formal definitions, what we really wanted to highlight here is that this kind of research has a really long and rich history and tradition of research that comes from communities, within communities, in reaction to other research where they were not included. Okay, these are images from people with disabilities in the disability rights community that I collaborate with a lot, that show you why they asked for this kind of research. They're trying to fight for equitable opportunities in society. They want their voices heard, and not just heard, but respected and acted upon, right? They want research that has a benefit, a value that they can take back to the community so that lots of people in the community can benefit from it, not just that one person or not just that research team. So I just want to remind you of that, and to know that there really is a really rich history that you want to read about and that you want to immerse into if you're doing this. And then also, as Susan put up this morning, I want to return to this graphic here that also tells you levels of community engagement can vary a lot in community-engaged research. On the left of this graphic, you're seeing more research where you're collaborating with the community. Right? And often, though, this is more led by the researchers and you're getting information back to the community. Where the more that you move to the middle and right on this continuum, the more that you're much more likely to get at community empowerment, because the community are true collaborators and partners in designing that research and all aspects of it, right? In informing you how to do it so it's accessible and participatory, and in some cases leading that research as well. Okay, so I just want you to remember this continuum, and you're going to hear of a lot of other related areas of research here, like participatory action research, PAR. People will talk about CBPR, community-based participatory research. You might hear about inclusive research coming from the community of people with IDD. You might hear about emancipatory or liberatory research where the community takes it on. All of these are kinds of community-engaged research and have informed it. The more you can get to the middle and the right side of this graphic here, the more the research about it shows you will have better outcomes, you'll have longer term impact, and you're more likely to be able to change policies and systems with that research. So there's a benefit to really trying to move along this continuum in your community collaborations. And then finally, we just wanted to share a few things to think about as you hear these next two community-engaged research teams presenting. And that is, what are some of the key issues from the community that they want you to know about, right? Priority areas if you're going to do this kind of research. The first one is, do you have representation and diverse inclusion from the community? So not just the token one disabled person coming to this, right? Or the leaders who always come and always show up for the studies, but are you getting a grassroots representation? And in order to do that, you have to have really tight ties with the community, and both of these groups are going to talk about that. The second one is about voice. And when I talk about voice, I'm not just talking about the physical ability to present or speak, right? Voice is a lot more than that. It's about, do you have a foot or a wheel in the door, a seat at the table? Is your voice heard? Is it listened to? Is it respected? Is it acted upon, right? So there's lots of ways to promote voice. The third one here is about meaningful and accessible and equitable participation. And you're going to hear many examples of that from our two community teams here about how they're trying to navigate all three of these in any given project. The fourth one is the research responsive to the environmental barriers that either prevent or make it really difficult for communities to really be an authentic partner in research, and maybe even prevent them from even knowing the research exists or is available to them, right? So could be societal issues like racism and ableism, could be environmental accessibility, or it could be financial and economic issues, and are we building those into our projects? So listen to these two teams about how they're supporting the communities so that they can actually truly engage. And then it's about power and control. It's always about power and control. I won't say more about this except to say it's central that the community has the power and is building the power, and that they co-own the knowledge that's generated, and that they also have leadership opportunities within the research team. And then finally, how does it move it to action, action, action is the number one request that I always hear from the disability rights community. How will this benefit us? How can we use it to benefit lots of people in the community? And those actions may take different shapes and forms. It might be just, if we're developing a new program or intervention, can we get it long-term after that grant, right? To actually work in the community and be sustained. It might be about systems and policy change, and it might be about community capacity building within, building the capacity of those members, building their identity, their culture, their pride, their sense of power, right? So all of these are viable actions that you can think about with community-engaged research. And with that, now, I'd like to hand it off to our community-engaged research teams to share many more things here, but I just want you to think about this throughout the conference and these categories. So I will hand it off to Kalila Johnson and Tracy Gaines to give us our first example.
All right, thank you. All right. I promise I can chew gum and walk at the same time. So, let's see. Do you need to say anything about that? Okay. Okay. Oh. All right. So, good morning, everybody. Again, I am Dr. Kalia Johnson and
Tracy Hawkins.
And we are really excited to kick off our panel discussion with a somewhat brief discussion, or presentation rather, that we have entitled Bridging Community Engaged and Action Research Approaches to Address Racism and Ableism in Health Services. And so before we do that, I do have to take a moment to acknowledge the Disrupting the Cycle Collaborative. That is the group of co-researchers from the community in North Carolina, without whom this research would not even be possible, to the Robert Wood Johnson Foundation Health Equity Scholars for Action program. And I am smiling and nodding at Teal Benavides, who was the person who encouraged me to even apply for that grant, who funded the work, and to the American Occupational Therapy Foundation for the invitation to speak to you all today. And so before we really get into the weeds, right, or the highlights of what it means to engage multiply marginalized folks in action research, we believe it's really important to provide context about how it is that we enter into the work. And so I am going to turn it over to Tracy.
Thank you. Good morning, everyone. Again, my name is Tracy Hawkins. I am a wife, a mother, and a tech entrepreneur with a background in community-engaged research during my days when I was a program manager at Duke Cancer Institute Office of Health Equity and Disparities. And fast forward several years later and 3 kids, it was really motherhood that carved out a new path for myself. My younger two sons. Both were diagnosed with autism and ADHD in 2018, just 7 months apart from one another. And during that time of trying to really navigate how to parent three different boys and help them each kind of navigate their space and their environment in a way that was functional for them, I stumbled upon a gap when it came to assistive technology and realizing that we needed more for our young kids to learn these skills. If they had these challenges with executive functioning, organizing and structuring their day and their routines, we needed to help provide them with the resources and kind of platforms to do that. So as a mom trying to figure it all out, I had an idea that I was going to be a tech entrepreneur. And I do not have a background in technology or business, but I said I could do this. And I was able to create our Thrive app. So after creating the app, I was then introduced to Dr. Johnson. And this is where kind of like my two backgrounds in that, Office of Health Equity and Disparities and kind of being a part of the disability community through my boys, I was introduced to Dr. Johnson. And initially I was attracted to her because it was a Black woman doing meaningful community engaged research. She wasn't just talking the talk, she was walking the walk. So I am very excited to be here today with you all and kind of share the incredible just nuggets that she was able to offer to our community.
Thank you, Tracy. So how did I get into the work? Well, I am a Black and female identifying OT practitioner who's worked with people with intellectual developmental disabilities, if I can get it out, and their families in Georgia, North Carolina, and Virginia. My interests in healthcare access and utilization in particular were largely influenced by my experiences working in home health, in group homes, and intermediate care facilities for people with IDDs. And one of the observations that I made very early on in my career, and side note, I've been at OT 18 years, was that although I lived in large racially and ethnically diverse communities, my patient pool was largely white. And these are historically chocolate cities, and if you don't know what a chocolate city is, it is a city that is predominantly Black and or has a large Black political representation. So we're talking about Atlanta and Durham, North Carolina, where there is more than 60% of Black folks, right? But I could count all of my Black patients on one hand. So you could probably understand my confusion and also frustration that I wasn't accessing and seeing people from my community. Well, as I made the transition from clinician to academician, I made the same observations when it came to research, particularly how white researchers essentialized and tokenized Black research participants, the lack of care and attention that was given to accommodation needs of disabled research participants, and then the complete erasure of those who live at the intersections of both of those identities. And by the end of my training, I was left with more questions. Questions about research processes and how some of our research seems to perpetuate the very injustices in the community that I was serving. The perpetual logjam that we seem to be in about how and why community health services remain inaccessible to Black people with IDDs, and why we continue to theorize about systems of oppression but fail to confront them as part of our work. So this led me to talk about or think about systems level questions, and I had to decide that in order to confront these challenges, I was going to have to commit to doing things differently. So to engage in research that had impact on the lives of Black people with IDDs specifically, I had to broaden the inquiry. Right, to think about systemic and structural determinants that impacted how they access their care. And then narrow that inquiry to determine the specific ways that those structural determinants, and specifically structural racism, were experienced by the community. And with the community leading the work, framing research in a way that would help us collectively, so not just the researchers and clinicians, but we're talking educators, community folks, the students that we're supposed to be mentoring and taking this work up after us, how we were going to get off the hamster wheel. standstill, right? The inquiry loop, because action was long overdue. Black people with IDDs and their families deserve more than years of being interrogated about what facilitators and barriers are, and more about what are we going to do about it. So one of our partners from North Carolina, Deja Barber, said this to me about working with Black disabled folks in the area. Because I do not take for granted that as a Black woman, I have access to this community. I am first an agent of the University of North Carolina, Chapel Hill. That's what she said. You are an agent of the state. And he's like, you know what? I am. Like that is how I pay my mortgage. You know? And so getting over that, right? That first, acknowledge and recognize what my position is in the university, and then what do I do about that, and engaging Black disabled communities as a Black researcher, particularly at the University of North Carolina. And she said, when working with the African American community as it relates to research, it's important to be cautious and effective when wanting to work with us. Our community is generally very fearful because in our heads, you are looking to find something and you're gonna break us down to find it. For that community and disability community combined, it is easier to get insightful research, but many see it as treatment and not steps towards action. And as a Black disabled community, we are willing to talk about the issues and say what went wrong, but making us think about it can sometimes be, or think about things can be different, is tough sometimes. Also, if families view it as effective, they usually want to keep having that treatment, but don't want to comprehend why it has to end. So referring to coming into communities, extracting, and then not seeing us again. Let me use my right hand. Oh, there we go. Ooh, nope. Okay, y'all. I know I said I could chew gum and walk at the same time, but yeah. So, you know what? Let me just go off this. So we really have to think about then, what does it mean to really work with Black people with IDDs, right? It's about situating the work at the intersections of race and disability. You can't work with minoritized communities and not call things what they are, right? You are dealing with Black people and Black issues, disability community and disability issues. I have to think about those things at the intersections. You have to recognize that there are racialized differences in access and utilization, right? These aren't things that we just theorize about and can publish about. This is real life. And it remains a persistent issue. And that this community has distinctive challenges that are unique and have to be approached in unique ways. And our families continue to describe their experience as constant struggle, and that is not to be taken lightly. And as it pertains to how we engage that in research, we also need to understand that it takes more than research skill to do this work. There are lots of people in this room that have amazing training at some of the top universities in our country, and that is great. But sometimes the social context, right, and the needs of these communities require a different type of skill set, a cultural skill set that you don't necessarily get in the classroom. And what I mean by that, right, is that we also have to attend to that historical, the intellectual, and the political context, right, the intersections of all those things. So what is the history, the disability history in our country? What is the history of subjugation of Black people in this country? How do those things come together in a very political way that impacts how people access healthcare and utilize healthcare in ways that are culturally affirming and safe? And so I did this with an amazing group of people, all who are not pictured here, but include Black autistic self-advocates with and without IDD, CP, ABI, and other DDs, their care partners, family advocates, providers who are predominantly occupational therapy practitioners, disability activists, community agency representatives, so folks from the ARC, the Autism Society of North Carolina, and a few others, academic partners, and a legislator. We use critical participatory action research to engage in this work. And it's really a framework that helps us name and frame what the issues are, but more than anything, gives us some tools, right, a guidepost in how to transform the issues that we are identifying as part of the work. And the phases include some reflection, planning, huge emphasis on ACT. Really, that should be bold and in all caps. And then going back and doing more observations about what worked, what didn't work, revising the plan, implementing it, and so on and so forth. Very iterative process. You can't think about it linearly at all. But more than anything, it centers research partners. It elevates them to the position of co-researcher. We hear about advisory groups. Advisory groups are great. I have nothing against advisory groups. But in CPAR, we're really on the right side of that graph that both Joy and Susan share. It's about empowering the community to take action. Researchers provide the framework, we provide the money and some of the infrastructure, but it's really about the community leading. But it's not without its challenges. As much as I love CPAR, I love research, there are some inherent structural challenges to engaging it, particularly with communities. And I think we could probably all agree that that is true of all of our research methods. But how do you flatten power hierarchies, right? Research is research, right? PIs are positioned as authoritarians, as experts, but the communities are also experts. They are experts in their experiences, they're experts in what is doable and the infrastructures of their communities, and so that should be or this particular method helps us leverage that in a way that flattens those differences. Integrating inclusive engagement processes. As occupational therapists, this is always at the forefront of our minds, but again, there are some inherent structural things that are part of research that we have to keep in check and make sure that we're using those inclusive strategies, not as additives, but things that are structurally embedded in the research process. Dissemination, if you're on tenure track, you already understand the struggle. There are particular products that are valued over others, and so how is it that we make sure that we are engaging dissemination practices that are valued by our communities and finding balance between those things? So for every academic product that we produce, I'm like, okay, let's make sure we have it one and preferably two that we're doing in the community. Institutional gatekeeping. Who controls the purse strings, right? So, and that happens on both ends. It's not just necessarily the money, right? But Deja reminded me, I'm an agent of the state, you know? So there's some additional gatekeeping in that regard. And then I think the biggest thing to remember is that in this work, we are confronting racist and violent systems. And so as a researcher, we cannot enter in this work without being prepared to deal with these things, right? How are you managing structural racism as it emerges as part of your process? How are you confronting and dismantling racist things as it happens in the community when you're dealing with providers or what have you? But also, what is the makeup of your research team? You know, we talk about representation as far as co-research. Who else is on the team? Who are you partnering with? But also, when these issues ultimately come back to the community as you're doing this work, what protections are in place to ensure that your community members remain safe? Okay, so I got into this a little bit already, but again, attending to historical, social, and political context when we're talking about strategies to mitigate some of this. And historical, I don't mean just sort of in the context of the United States, but you know, I am not a native to North Carolina. I came to North Carolina in 2012, so part of the work that I had to do, even as a doctoral student, was understanding what has happened with the disability community and Black disability community in North Carolina. What did it look like, particularly in the triangle where we are very resource rich. So that's Chapel Hill, Durham, Raleigh. You have 3 very large academic institutions and 2 large academic hospital systems. So understanding what that history is like. What is the social context? So what is the relationship between the university and the community? And then the politics of all of that. Already touched on inclusivity in terms of how we engage people with IDDs, so I won't go back to that. But cultivating relationships, the people that are part of this collaborative, some I have known since 2012. So I want to make sure that I emphasize that you have to take time to build relationships. Deja was introduced to me through another partner that I had known for several years. And it took a lot of emails and a lot of phone calls and a lot of text messages before Deja would even have a conversation with me. So persistence is key. Remember, I'm an agent of the state. Being transparent at every step. We often had calls. I was at home. They could hear my daughter screaming in the background, and I'm just saying, like, it's a tough day. We're all gonna get through this. Sorry, things are happening. So they had a glimpse of what my life was like, not just Kalia the academic, but Kalia the mother, the partner, the, really tired community member, where I'm just like, I don't feel like meeting tonight either. Let's just chit chat and call it a day. Soliciting and implementing partner feedback. And this is not to be treated like a program evaluation at the very end. Every meeting, it was revisiting issues, how is it that we should be addressing this as, academic partners? Does this meeting even work for everybody? Does the time of day work? Do we need to make adjustments to the agenda? Agendas were set by the partners, but even in real time, we're like, we don't want to talk about that anymore. Okay, easy fix on the Google Doc, that sort of thing. And having multiple modes of communication. And when I say this, I please don't hear this as I am going to appropriate African-American vernacular English. When we talk about modes of communication, it's more than, is it on email, is it printed, or that sort of thing, but what is the language you are actually using? Keeping in mind that using academic jargon, one, is not necessary. We don't talk to each other that way in normal conversation. We don't need to talk to partners that way either, but meeting the communities where they are, and that is not to say that if there is some slang or something that is part of the community that they're using, you just need to understand what it means, right? And not to necessarily mimic that, but meeting people where they are with your communication as well. Okay, so I am going to stop talking and turn it back over to Tracy, who can really give you some insights from the co-researcher experience. Thank you all.
So this is the exciting part for me because, again, remember, I came from, in my working days, where I was educating and training researchers on how to do community engaged research. When I came over to Dr. Johnson and was able to serve as one of her research partners, I was able to sit back and enjoy it because this is a woman that knows how to do it, right? So some of the things that I just want to touch on now is how intentional she was in establishing the relationships with us. As you saw some of the pictures, they were in her home. The community partners, we were able to come together in her home. We were able to engage with her daughter. Really, like she said, get to know her. The email communications and study updates came from Dr. Johnson. They did not come from a staff member. Dr. Johnson was updating the community partners monthly. Another thing that we enjoyed about Dr. Johnson is she came to our events. If we were hosting events, if we were participating in panels or doing keynotes, Dr. Johnson was in the audience, right? She was there to support us. The writing process. So when Dr. Johnson presented the opportunity to kind of come aboard and help her with some of the manuscripts, it took me back to my graduate school days, and I was like, oh my God, I don't think I want to do this. Like, bad memories of it. She broke it down. She did a full presentation on what it means to write the manuscript, right? What does it entail? What are the responsibilities? What does it mean to be an author, right? So we had a full presentation on that. She honored our voices in the writing. So just as she was saying, the way that any of us within the partners spoke, that is the way she put that in the paper. She didn't try to change like you said, make it more academic or change it. She kept our voice. She ensured that all of us within her team attended conferences, attended podcasts. She just made it so flexible and had a number of different ways that we were able to participate. Another thing that she did, I think she was very flexible in the way that we were able to participate. So it was not a one-size-fits-all approach to being a community partner. Sometimes there would be opportunities where some of us on the team needed to kind of fall back a little bit, right? We didn't have the capacity to do any more, but she still made it so that we are part of the team, right? She honored where we were and what we were able to put on our plate. We had opportunities to expand our network because we felt like a close-knit team that we started forming our own partnerships and collaborations as a team. And I would say another important thing is payment. We didn't get paid at the end of the study, we got paid after every meeting. So again, this is a researcher that wasn't just talking the talk, she was walking the walk.
Thank you. And that money piece, y'all, we could have a whole conference about reimbursement. So we'll talk about that later, but thank you, Joy, reminded me. We actually only have like 4 minutes left. I went way too long. So just really briefly, you all can see what some of the products, like broad products and outcomes of community engaged work can look like. I know Tracy did a lot of reflecting on sort of how like what I did in the process, but I want to highlight that community partners were empowered to do a lot of work on their own. Like those things that I showed up to were things that they collaborated with, whether in meetings or outside of meetings, to disseminate in the community. So between health fairs, meetings with other legislators, doing some organizing work, right, to deal with some of the things that were happening between disability communities and police, so on and so forth. They've sort of built capacity to do that work themselves. We also, doing this work helped us cultivate some relationships with organizations that specifically do work around social justice and disabilities for the Black community. And so it really took being creative about how to disseminate the work so that those agencies would want to partner with us. I think we, as researchers, are always in the habit of chasing the groups and chasing the money, but this project really was affirming to me that this work is worthwhile when the North Carolina Black Disabilities Network said, like, hey, we want to talk to y'all. So that was a really special moment for us. Again, the conventional academic outlets, like where we are today, but also being solicited by funder-specific dissemination outlets. The podcast, that is done by Tulane University School of Public Health, the one that we were mentioning specifically. But it also, another plug to AOTF, it informed another project that I was able to get funded by them through the Health Services Research Program. So the take-home messages, and we can continue this discussion at the end of our presentation with 1 minute left, is that research questions matter, right? Remember, broadening and narrowing that inquiry, really thinking comprehensively about that. And the community has to know who you are. You got to get over the agent of the state hump, right? So this can't just be a professional commitment. It has to be a personal investment. That transparency cannot be compromised. Again, working actively to flatten power hierarchies in the work, and that you have to include strategies that are going to address structural determinants, not just in the research itself, but in, or outcomes of the research that is, but your research processes. And I'll leave y'all with that quote. Thank you.
Oh. How do I go? Okay, well, I'm Dorothy Edwards, and I want to just give you briefly a little bit about me. I'm obviously a white, older woman. I'm a professor at the University of Wisconsin-Madison in the Department of Kinesiology, which is where the occupational therapy program, but I'm also a professor in the Department of Medicine. I lead the Collaborative Center for Health Equity, and I'm a co-PI of the Community Academic Aging Network. But I want to go backwards in time to 1972. I know many of you were not around in 1972, but I was a first-year graduate student at Washington University in St. Louis, and I had no money. My stipend was $215 a month, and I needed a job. And so the Older Americans Act was just being funded, and the St. Louis Area Agency on Aging was being founded. And there were a group of black elders who were bringing their community-based programs for older adults under the Area Agency on Aging umbrella. And I had the great privilege of having mentors from the community when I knew nothing. I sounded like a 12-year-old, and they didn't believe I was actually in graduate school. They thought I was a high school student, but they took me under their wing, and for 20 years, this group of wonderful individuals guided me through my work in St. Louis. And I got funding from the National Institute on Aging to create a satellite program for people with Alzheimer's disease through the Alzheimer's Disease Research Center. This was in 1991. I submitted the proposal. I went back to my community team and I said, I think I need to do a needs assessment. And they said, Dorothy, if you don't know the needs by now, you shouldn't get any money. They were good advisors to me. They said, we need services. So I actually created the first service-based research recruitment program in the country. We put the program in the St. Louis Area Agency on Aging. It was led by a nurse, a social worker, and an occupational therapist. And we did home-based diagnosis and care management. I'm interested in occupational performance and complex life activities in people with cognitive loss. They let me into their homes to actually see how they function. And then individuals who are willing to participate in research were referred to the Alzheimer's Disease Research Center. It was considered a very innovative model. Then I moved to Madison, Wisconsin in 2005. And I will show you my partner who helped me in the Milwaukee community. I was in the community for 3 years with my colleague Gina Green Harris and learning how to work in the Milwaukee community. And Milwaukee and Madison are really tightly connected, and that gave me the credibility to do my work in Madison. But we work with a program funded by the National Institute on Aging called the Community Green Button. Well, I want to say we're funded, oh, green button. So my slides are moving, but yours aren't. Okay. There. So this project is funded in 2 ways. First, by the National Institute on Aging. It's called the Community Academic Aging Research Network. The acronym is CARN, and I'll be using that. But we also have support from the National Center for Advancing Translational Sciences, that's NCATS, through the CTSA program. And here is our CARN team. We are Dr. Jane Mahoney is a geriatrician. Her area of expertise is falls. That's a really great picture of me on a very good day when I was younger. Dr. Barbara King is faculty member in the School of Nursing. She has really focused on research with PCORI funding on rural elders and bringing rural elders services that they need. Dr. Eva Vivian is a professor in the School of Pharmacy, and my good friend and colleague, Ms. Gina Green Harris, who is the director of the Center for Community Engagement and Health Partnerships in Milwaukee. She's doing really seminal research with community advisory boards. She's really trying to figure out whether community advisory boards actually are empowered enough to give advice, and whether the people who organize community advisory boards actually take the time to listen to them. And I think this is really important. This is my colleague, Carla Peterson-Gaines. This is Dorana Woods, is another of our community research associates. Mia Croyle is a community research associate. Will Palmer is our program director. And Jovita, what's Jovita's last name? Hogan. Hogan is our administrative support. And this is our team. So the R33, I just want you to know that the National Institute on Aging actually does fund support for community-engaged research. It actually was submitted once and not funded, and then it went back in. They didn't really believe in the model at the time. But what we wanted to do was to really look at community-based interventions for rural and African American adults that would be feasible, have a broad reach and be able to be adopted, promote health activation, empower community residents to engage in goal setting, shared decision making, and lead to changes in improved health and quality of life. And we function, research is very hierarchical. I'll be the first to acknowledge it, but we function as a very horizontal team. In other words, the decision making is made collaboratively. If there's a project brought to the team and Carla says, I don't think it's going to work, I'm uncomfortable with this investigator, all they want us to do is go out and hand out a bunch of flyers and then they're going to count how many people we get, we don't do it. I would never presume to question her judgment, or Dorana's, or Mia's. But what we wanted to do was to really work with existing structures that people in the grant had worked with, really to train research liaisons on how to partner with community, with organizations and individuals. We had multidisciplinary experts like me to consult on the research design to make sure that the designs were appropriate and effective. And then we have community advisory boards to provide input throughout all stages, from the very beginning to the very end. And then we have tailored advisory boards that are subject matter experts to make sure that our community research associates, our community partners, and our investigators, often who are new at this, have the expertise they need to effectively do their research. So what are our values and missions? One is to respect and honor our community partners' inputs. They're the experts. To bring projects to the stakeholders' table, to compensate community partners for their work, to be present and give back to the community, to hire from the community and build community capacity when possible, and to conduct research that's high priority to our partners in the community. In other words, we're not going to just take any project out because the investigator has money and they want to do the project. Now, just like Kalila, I work for the state of Wisconsin. The University of Wisconsin is a state agency, and I will tell you that it can be an incredible challenge. We gave you some background reading and papers. For one of our community events, my good friend and colleague, Carla, made a green bean casserole because we were serving lunch to people coming. You would not believe what it took to compensate her for the ingredients for the green bean casserole. We're not talking about more than $100. We're actually talking about less than $50. And it would have been easier if I just said, here, Carly, here's some money. But she didn't want to do it that way. And so, you know, the accountant in the Department of Medicine, why are we paying for green bean casserole? Where was it sourced? Well, it was sourced in her kitchen. You know, are they an approved vendor? No, she's my research partner. You know? So anyway, these are the things that happen. So what we noticed with the CARN network was that we needed new partnerships, that we needed representatives from the African American community. That was the African American Healthcare Network. We needed rural community representatives because remember, if you know, because I know you're getting the commercials for the election, the state of Wisconsin is, you assume, is predominantly only white. This is not true. There are black people and Hispanic people and Asian people in Wisconsin. We needed representation from healthcare systems, and Metastar is our partner, and we needed multidisciplinary expertise. And so, we have co-investigators from pharmacy, from nursing, from engineering, from the vet school even on occasion. So we bring in partners as we need them. So how did we know that this was working? Well, these were the criteria set by the National Institute on Aging. I don't think this would be surprising to you. These are quantifiable, measurable outcomes. And here's what we did. So during the previous project period, we've just ended our first 5 years. You know, we tested cultural adaptations for evidence-based programs. in the Black and rural communities. We tested mental health interventions. Carla is also working on those in the Black community. Self-management through voice-activated smart devices, that came from the School of Engineering. Testing of interventions to support well-being of persons with Alzheimer's disease and dementia and their caregivers. This is Beth Fields, our occupational therapy faculty member who was at Colorado, trained at Pittsburgh. Recruitment of Black older adults into Alzheimer's prevention studies to improve the abysmal rate of participation in Alzheimer's drug treatments. Their first drug approved for Alzheimer's disease had, count them, 9 African American participants, and the FDA approved the drug. 9. Recruitment, new methods to identify long-term and cultural and cognitive effects of COVID. That's us, so we're going to be talking about that. And really looking at collaboration with community health workers for cancer screening in the community. So what did we do? We actually had a lot of really effective investigators who secured 26 grants, $12.7 million, which 11.19, we have very, very wonderful intramural funding at Wisconsin, 19 research projects, collaboration with 41 community and 3 healthcare projects. So it's working. But this is the CARN team in action. You'll see, this was actually from, I think, a week ago at a health fair. It was, they were promoting a driving and dementia study, equine-assisted therapy study. This is Beth Fields, who's bringing her equine-assisted therapy from the University of Colorado. Now it's working with elders in Wisconsin, a depression study that Carla's working on, and our long COVID study. But they're out in the community all the time. Usually I am out there with them whenever I can. But now I want to just briefly set up our long COVID study and turn this over to Carla. So we were fortunate enough to get funding for a study of long COVID. Now, occupational therapists, unfortunately, have not been involved enough in the identification and treatment of long COVID. We know from talking to people who are living with long COVID that there's tremendous disruption of their occupational performance in their everyday lives. Unfortunately, none of the NIH-funded studies actually include measures of occupational performance or of complex functional activities, functional cognition. National Academy of Science, in their recent publication 2 months ago, just suggested that maybe it would be good to add measures of function, not functional cognition, not occupational performance. So I was really fortunate to get internal funding with a collaborator who's an infectious disease specialist to begin to look at this and look at disrupted occupational performance. But what we wanted to do is we really, really knew that the burden of long COVID is being borne by Black and brown communities, but individuals are not being represented. The big study, the RECOVER study that NIH has put millions and millions of dollars in, you know, it was about 60,000 people, but you'll see that only 20% of the participants in the RECOVER study were Black. There were no measures of functional cognition or occupational performance, so we decided to do our own. And so this is why we're doing it. We know that brain fog causes disability in daily routines. We know that disability isn't well understood and there are no good clinical definitions. We know that clinicians don't have enough evidence on safe and effective rehabilitation, so people with long COVID are being referred to physical therapists and to speech therapists, not to occupational therapists. And therefore, they're leaving their therapy without having their occupational performance needs addressed, and patients don't get the rehabilitation that they need, and their disability persists. And we wanted to make sure that the African American community were fully engaged in our study. So that's where my partner comes in. So I was fortunate enough, I'm an investigator in the CARN study, but I know what I know about it, and so I brought the preliminary design for the long COVID project to CARN and presented it to our community research associates, and Carla was kind enough to say, I'm interested in this. And she's my partner, and she connects me, she guides me, she facilitates me, and she ensures that my study, our study, is true to the community and meets the community needs. And she is very much involved, in fact, leads the health ministry at Mount Zion Baptist Church in Madison, and Mount Zion has become our community partner, but Carla is in the middle making it all work. And I'm going to do one more slide, and I'm turning it over to her. Here are some of the things that we did. She leads a Wellness Thursday health topic on Zoom every Thursday. She really worked on and revised our recruitment materials, and this is a group at one of our community education sessions at Mount Zion Church, the famous green bean casserole day. And so she has been an integral part in the reason that our study has been successful. And these are all the things she did. I will say that our current participation as of yesterday is 36% African American, so we've exceeded our goal. And it's only the beginning of the work that we're going to be doing in the community. So without further ado, this is Scarlett Peterson-Gaines, my colleague and friend.
Thank you, Dr. Dorothy. Thank you. Wow. Trust, passion, motivation, dedication, thrive. That's community. My name is Carla Gaines. I am excited to be here today at the inaugural event. I am just so excited. I want to personally thank Dr. Dorothy Edwards, who I admire a lot. Not only because of the great work that she's done, but because she is transparent and true to the community. As she said in 1972, I'm glad she tells that story all the time, but yes, she is the white woman. However, she has planted herself within communities way before work that she wanted to get done. She was engaged in the community, engaged in what's going on in resources, providing some of those resources before she ever talked about her work. And so again, my name is Carla Gaines. I'm a nurse by profession, but I am the Community Research Associate for CARN. I'm excited also to be on the panel with phenomenal women. Dr. Joy, great meeting you. To my dear sorors that I met last night, Dr. Kalia and Tracy, Soror Tracy. So I was at a conference a couple of weeks ago, and the keynote speaker said, when you enter a room, so we've entered the room. We are not here to match your energy, but we are here to transform and shift the trajectory of the room. So that's what we're here doing today. We're going to shift the atmosphere when we talk about community participatory research. And so Dr. Dorothy set the stage. I'm just going to talk about one of our projects that we did, and that's the long COVID study. And I said yes to that because we saw our Black families, people that we knew, die. During COVID, at 11 o'clock my time, it was probably Eastern time, 12 o'clock here, Governor Cuomo came on with his statistics every day, looking at those body bags, seeing the hospital nurses and doctors just overwhelmed and burned out. Remembering even in our community how they were asking volunteers just to come in to check in people at the door to screen them, and our health plan and did those types of things because we were trying to alleviate some of the burden from the staff. So I remember that piece and praying every day that I didn't get COVID during that time. A little bit about me, I'm married, I have 3 grown children, but my grandbabies, the last one was born during COVID, and she had a birthday, 1-year-old birthday, and it was in Houston, Texas. And my husband said, risk over reward. And we decided to go to the birthday party. However, on the airplane, and we decided to get our own hotel room. We were not staying at your house because these are young people. The young people, they were like, COVID, well, no, what? You know, my daughter told me she's gonna have a mask and a hand sanitizer there, and I'm like, great, we're staying at the hotel all week. We're coming back to your house. We're staying at the hotel. So when we left on the airplane, before I left, I ordered, I can't believe now that I really did this, but I really did. We had on masks, what were they called? N95. I had the shield. We had on gloves, latex gloves, and we had the white overall plastic suit on the airplane. Like, we were like, not getting it. No, because I saw one of my dear friends die trying to take care of her mother-in-law. She contracted it, and she died. And I'm like, risk over reward. Birthday, yes, but we got to protect ourselves. We're over 60. We got to protect ourselves. And so as soon as I got to Houston Airport, that plastic suit was so hot, I ripped it off immediately. But I was protecting myself, still masked up, shielded up, we were all ready. But I remember that time. So when Dr. Dorothy came to me and said, would you be a part of it? Because I am the co-partner with the, with the African American Health Network. And they told me I had 5 minutes. Now, see, that is not fair. And so I definitely wanted to be involved. So, her students, I met with her students and her team, and we talked about community and what that really looked like in our Black community, and how are you going to come into our community and help us understand what this long COVID is about. Dr. Dorothy already mentioned, she has already been in our community. People know her. Our leaders in our community know her. So they know that she's a trusted entity, right? So I met with her students. She talked about the flyer. The first flyer they sent to me had white people in it. I was like, okay, did you want me to recruit Black people or white people? So they switched the pictures. We got that flyer taken care of. And as she mentioned, we have a great community partner, Mount Zion Baptist Church. I'm the health ministry co-chair there. We do tons of work with diabetes. We work with other partners. Our other UW health system is just huge in Madison. Stroke, hypertension. So this fit right in to our Wellness Thursdays that I wish we did once a week, but we do them once a month. And she brought her team in, and when COVID came, we went virtual. And so it was an opportunity for all of our church members and community to have that Zoom link, be involved, ask those questions of this long COVID. Because people were saying, I can't remember things. I don't know why. Why do I keep having this cough? Like, when I was trying to recruit people, they said, you know what, I really want to get involved because I don't understand why I can't smell things anymore. Yes, I want to be involved in that. And they saw me as a trusted entity to bring folks into this study. And so we worked with our team, our Wellness Thursday. They educated us regarding COVID and long COVID, and we began to reach out to other organizations. And so what Dr. Dorothy said, you know what, in June, let's have an in-person type of meeting, June of this year. And that is what we did. We brought several community members, community partners to the church so they could talk about the long COVID study and also do testing while they were there. On her study, there's a stipend. But the stipend is not gift cards. Everybody wants to give you a gift card to where they want the gift card to go to, or who they want to get you gas. What if I don't have a car? Why do we give me a gas card? Her stipend was cash, $50 in cash. That means you have the power. We talked about it. The power, giving the power to the community to do what they wanted to do with their money. That they invested their time, their transparency of them into the study of asking questions. And so that was very powerful for that. When they came that day, we had about 30 people there. I said, Dr. Dorothy, we need lunch. That's what she was talking about. This is money that we needed. I needed lunch because I'm having a caterer. We're going to have a Black caterer, and she's going to do, and this is what she needs in order to do this. Dr. Dorothy said yes. Also, we wanted to give them gifts. I am a lover of giving. And so if you're going to come, we have something for you. Not only beside if you participate in the study, but just for coming for your time, because your time is valuable. The community's time is valuable. And so and also what we did that day, we had different community partners around the room tabling. So we had another research project there that I also work on, CB Faith, regarding a depression study. We also had Black Women's Wellness there, talking about other health in the Black community. And we also had one of our community leaders just talk about, she developed a whole community clinic within her community. We had her come. So they had resources around the room so they could walk around and get more information besides what long COVID is about. And so when the research team got there, her research team got there, they had, I think, testing maybe for a few people. And when I walked around the room, they were like, when I was talking about the study, they were like, oh yes, I want to be tested today. Yes, this is the target audience, they're here. They said, well, we only have but 5 tests. Well, I think you're going to have to go back to the office. So they went back to the office, got all of their material, came back, and did testing that day. And the testing was questionnaires. And we had private rooms downstairs where they were able to do that. And so they were able, again, they listened to what I said, and they acted upon it. They said, okay, yes. And these are young, at 20 at least. I'm 66, so they were young. And they came back with the material. And so it was successful because we had the target audience there, and we were able to do that. And so that is what partnership, listening, being engaged in community is all about. And what Dr. Dorothy is also going to do, after she puts in what she needs to do, she's going to bring back that information to the community. Because sometimes researchers come in our community, they do their work, and then they leave. We want the Black community to do this for us. We want to research you on this. And then you don't see them anymore. They at Chapel Hill, they're at University of Pittsburgh, they're at Penn State. I'm picking up my sword because I know she already loved me. But they don't come back and tell the community what they're finding. They don't put the resources back in the community. And that's the important piece. When you get done, come back into the community. Let them know what your study was about. Give them the resource to continue the work so that they can thrive. And that they continue to survive and continue to have resilience, because they already have it, but they can continue to do the work that will make them have a well-lived life and how they want to do it. Because that's the first thing. How does the community want to have this well-lived life? You have to make sure that is key, and that's where the trust is also the foundation. Thank you so much.
A very big thank you to our excellent community engaged research panel. Another round of applause. Excellent. In this last part, I'm wondering if you could put the slides from the intro back up, way towards the end of it. There's a community conversation slide that I also left a QR code for you in case you want to enter some information with us electronically as well. So we are now opening it up for questions from the floor, and I will.
Oh, I've got it.
You got it?
Yeah.
Excellent.
Good morning. Thank you so much for your panel. My name is Dina Gesner, and I'm from Drexel University. And I'd really love your insights. As community-engaged researchers, we are more and more aligned with, in our situation, addressing the needs of the autistic community by using the language preferences that they prefer. For example, getting away from ASD, which is a 2-letter lazy way of saying autism. Because we don't like the word disorder, right? There's so much medical model expected in many of these grant applications, which is very harmful to the very people that we're working with, and they've already told us that. Do you have any suggestions about how we as researchers can try to shift the culture away from the medical model, especially with occupational therapy that's very medically driven, and for good reason in many ways, but in terms of this kind of advocacy and empowering work, how we can shift them away from that and allow us as researchers, as we apply, to use the language we've been charged to use?
And if you could just repeat the question, a paraphrase of it, before you respond, please.
Okay. So the question was, how, as researchers, can we sort of shift the culture around the types of language that we use in grant applications and use language that is preferred by the community? That's a really good question. I will give the example that happened with me. It's like, I always believe if the door opens, like, just go ahead and kick it in, right? So the Health Equity Scholars for Action program that funded the work through the Robert Wood Johnson Foundation, they awarded 15 grants, but they interviewed 25 applicants. They did an interview process to determine, like, who were the final folks that were going to get the grants, right? And during my interview, I took the risk and held up a mirror to, and these were board members that were also part of this interview, to say, this is where Robert Wood Johnson Foundation is falling short with people with disabilities, and talked about what their funding portfolio looked like, what I felt like was missing, the reason why they needed to pay attention particularly to people with IDDs, and why OT specifically needed to be funded, professions represented in part of their funding portfolio, and making sure that I was sort of naming structural racism, naming, like, the communities that were impacted, just being very straightforward and honest to say, this is how you can do better, obviously promoting the work in that, but also showing them, like, this is an opportunity, a missed opportunity if I don't get funded, right? And so using those opportunities then to do those necessary kinds of plugs. If they're, oh gosh, this happens in publications all the time. I actually just went through this with, I won't name the journal, but where the associate editor made a comment about capitalizing the B in Black. So having to do the additional education around, like, this is why we capitalize the B. You know, this is why I'm using, you know, identity first language. Asking me to remove direct quotes from a paper. And I'm like, this is erasure and this is why, you know, and then underline some of their own publication policies, like, you're not even following your own rules on this. And no, I'm not going to do it. Paper might not be published over it, we'll see. But using those opportunities to do that kind of work. I mean, it is extra labor, but it is necessary. And I'm glad you asked that question, right? Because it won't get better on the structural ends of things and how we fund and everything as researchers if we're not challenging those systems.
Thank you.
You're welcome.
All right, who's next? Hello, thank you so much for your panel. My name is Miranda Donnelly. I have a question about capacity building for research engagement, because on one hand, I really want to break down these norms. We talked about some of the sort of historical foundations of a lot of the norms in research institutions. We want to break those down. But I also want the community partners I'm working with to feel equipped to participate in research activities as we also try to evolve systems. How do you recommend kind of prioritizing how we're building capacity, how we're going to make research more accessible without just reinforcing existing structures that we're trying to change? Because I'm really struggling with that, and I would love to know how you're doing that. Thank you.
So the question is how to build capacity and do it in an authentic way. So I will say I'm an NIH-funded researcher. So I mean, I've had some other foundation funding, but my work has been funded continually by NIH since 1986. So I'm working inside the system. I will be really clear about that. It really matters how you write your grant proposals and how you justify what you're doing. In other words, our current proposal was turned down the first time. The NIA didn't believe that the model was going to be effective, and we listened to the critiques and went back in. But our community research associates, we have a horizontal decisional model. We do not make decisions about projects unless our community research associates say, yeah, it's a go. I trust this investigator. Here's what we're going to need to train them. Here's what I need to know to do this work. And so we do additional, you know, they have opportunities, or we have opportunities to do quite a bit of additional in-service training, other kinds of training, so that we're bringing the team along. But you have to budget that. Okay, it doesn't happen by accident. And you have to work within whatever institutional constraints you have, which means fighting with the IRB to get your community partners in and city trained, even though Many universities have alternate training that the Office of Human Research Protections accepts, so you have to fight the policy, you have to know where you're going, you have to know the resources, and you have to put the money in the grant to make it happen. And so you have to know where you're applying and what the rules are and who's on the study section. But you have to do it, and it works. It works. We know that it works, but it sometimes takes additional effort and really understanding the system. I hope that helps. Anyone else? Also, alternate funding sources. You don't always have to go to NIH. It is a very medicalized model, but sometimes that's where the money is, and you tuck your stuff in. We always include measures of occupational performance, always. They may not be the primary outcome, but they're a secondary measure, and we're publishing as quickly on the secondary measures as the primary.
Good morning. My name is Tina Harris, and I'm a community liaison. I loved all of it. It was perfect. Y'all were fabulous. My question is, what's the IDD? I don't understand that.
Thank you.
Thank you. The question is, what is IDD? And thank you for calling that out, because again, another trap that we fall into, speaking to audiences about checking your language. So IDD is short for intellectual and developmental disabilities. So an intellectual disability is a type of developmental disability. This developmental disability is the broad umbrella, and IDD falls under that. Typically diagnosed before age 18. The American Association of Intellectual and Developmental Disabilities, defines it as having some limitation, not just in sort of intellectual skill, but also adaptive function. So also how someone is able to do the things that we do in everyday life. And so participants or co-researchers in disrupting the cycle that were the adult age folks who were participants from that community all had IDDs. So thank you. I needed to clarify that.
Thank you so much for this wonderful presentation. I'm Elizabeth Rodas from the University of Kentucky. I want to comment on the comment about autism and ASD. In Kentucky, we're currently getting rid of the words diversity, equity, and inclusion, and the University of Kentucky president put a hard stop a couple weeks ago in all of the programs and everything. I'm in the Center for Health Equity Transformation. We're now the Center for Health Engagement and Transformation. But it's an interesting dialogue when we go out in the community, or even when we're writing grants, saying we're doing equity work, but we're not allowed to talk about it anymore. So I really resonate with that. It's a hard place. They're telling us that people can now sue us personally if we offend them using these words. So that's separate and aside from my question for the panel. So you guys have a beautiful presentation with really rich champions, community champions. So thinking about all of us here, we probably have our community connections and our champions embedded, but do you all have suggestions for early career investigators or people going out in the field for the first time or in the beginning to find those champions and kind of build your team? What are the steps to connect with people and for the training so that you can build these wonderful programs?
I feel like everybody looked at me. So the question was, what advice would we give to early career investigators for connecting with community champions, that engage in this work? A few things, right? I think it's just making yourself vulnerable and not being afraid to just show up in spaces where there are people that you want to connect with, and just doing that sort of organic work to cultivate and hope that the relationships that you want sort of emerge through you doing that sort of participation. I leaned on mentors a lot, saying like, hey, I want to be introduced to these folks. Because 9 times out of 10, they will introduce you, The other thing is and this, this might be a very millennial thing, I don't know, but or even Gen Z, but using social media to call people in, invite people in to connect with you, to just talk about what you're interested in and what your goals and aspirations are. Like, people respond to that. And I know it's not always comfortable for us to do that, but some of the folks I've connected with, it has literally just been over Instagram. But also just giving yourself time and grace to do this work. Like I mentioned, I came to North Carolina in 2012 to pursue a PhD at UNC. So many of the relationships that are represented as part of Disrupting the Cycle started in 2012. Not 2019 and when I became a faculty member, or in 2022 or 21 and 22 when the grant started. But if you have mentors, if you do not have mentors, right, in the discipline who can't connect you, like, using part of the academic community to do some of that work for you as well. It is not easy to make those connections. When it came to learning about community engaged research, because that was not my training. I did a postdoc at Virginia Commonwealth University. Shout out to the VCU folks in the room, who really led me there. But the bulk of the mentors in that group, they were health behavior psychologists, not OTs, who I think really, really guided me in the work. So leaning on mentors, not being afraid to call people in, putting yourself out there, talking about your interests, to invite folks in to collaborate with you, and just showing up in the spaces where you want to connect with people.
So here's the advice that I was given. First, you show up. You show up, but you don't talk. You ask permission to speak, but mostly you're there to listen. Present when you're invited. Never make a commitment that you can't keep. Don't make promises, and then always remember what the community is bringing to you. In other words, it's not like you're the expert. We need their expertise. I was trained in a cognitive aging laboratory setting. I hated it. I really needed to be out and about in the community. Unfortunately, I needed a job, and that really set my career. And Elizabeth, the University of Wisconsin system also has no DEI activities, and in fact, the legislature would not allow the university system to give any employee a raise, not a single one, from janitors to faculty, until all DEI references were eliminated from the university system. So what we're doing is we're doing our work. We don't call it what do they want. We've just lost the label. We're not stopping the work. And so we're out and about and listening, active listening, and then saying, what can I do to help?
Real quick, I just wanted to add on regarding what I heard is young researchers that want to be involved in community. Example happened to me because of being on the staff of CARN. And so we had two white young researchers. They want to do a project. How do they let the community know? Because they needed some black entities to come and work on the project. I said, well, the community is having a next level. It's going to be a community concert in the community. We're going to have tons of resources, tons of black businesses there. Come, I will come to that, mingle with the people, buy some black products, buy something black, use your money to increase our economy, get to know them, talk to them, say who you are. Don't tell them about your research, just tell them who you are. You're happy to be here. Sit back in your lounge chair and enjoy the music. First, engage in the community, because trust me, we know who's there. As we can see in this room, y'all know who we are. And so,
dying to get in the conversation
Okay.
and ask some questions, so I'm just gonna...
Yes, I just wanted to follow up on that.
Good morning. My name is Ron Booz, UIC. And I, again, want to thank the panel and commend you. I recognize your expertise and your passion, of course. But I have a question in regards to the data that you collect. And again, commending you to want to put the work in and make the data applicable that's going to make a change. It's one thing to collect the data, but it's what you're going to do with it. And so I guess the question is oriented toward the atmosphere that we're in right now, and I'm not trying to focus on the political climate, but it has to be included because we all know, unfortunately, in this country, our dollars and where they're distributed is often controlled by whatever political power is in place. But where would you want and see within the next 5 years collecting this research and making it, again, applicable for change? Over the next 5 years, where would you want to see the most impact to be made?
Well, quickly for me, where would I like to see the most impact to be made? I would like occupational therapists to be compensated for doing occupational performance evaluations and therapy for people with long COVID. We don't have any evidence supporting the therapy, but we do know what works with other kinds of problems, and I want to see OTs engaged in supporting people with long COVID. That's what I want, and I hope my data actually brings that to place.
Excuse me, Tracy. A couple things come to mind for us. One, we would like to see, or using the data to inform how folks who interface with people with intellectual developmental disabilities in health and community, whether it's in clinic or in the community health settings, like making sure that the ways that we engage are culturally affirming and are anti-racist. So we're using data to inform a anti-racist provider intervention, and how we scale that up, we're not sure yet, but starting in North Carolina to say, like, at least our providers in our state are going to do things differently. The other thing that I think it's important for the researchers in the room to hear is that you have to have folks in the legislature as part of your research teams. Thankfully, Tracy is married to one of our state representatives, right? And so I do not use her as a channel to make sure I can get to him, but you know, I did pay attention to that. And we have to use part of our time to make sure that we are also in the places and spaces where those decisions are being made. So participating in the North Carolina Developmental Disabilities Council, being present at the North Carolina Black Disabilities Network, being present at the Autism Society of North Carolina meetings, like being present, being vocal, telling them what the project is like, bringing them on as partners so that change doesn't just happen in the research, but also how we're educating folks and making sure that it's on the minds of our legislators when they make these decisions to be like, oh yes, and people with intellectual developmental disabilities.
All right, love of the passion. We're trying to squeeze in one more question.
Can I just ask Susan, as the moderator, I just want to ask Tracy and Carla, where do you want the priorities to happen from community perspective in the next 5 to 6 years?
I think what Dr. Johnson said, like, that's why I was shaking my head so hard over here, is because seeing my kids go into these clinics and having some of their providers already approach my 8-year-old son with, you know, hesitancy, within the first 4 minutes of the session being told, oh, it's not a good session, things are not going good, if this continues, we got to stop. Like, are you giving that same level of, like, compassion to your other clients that do not look like my son? Like, those are the things. So hearing that response was like, yes, that's where I want to see the money.
Yes, real quick, just in order to see the dollars move, again, the trajectory of Black people in their health wherever they are in the spectrum. Thank you.